Welcome to Straight Talk with My OBMD podcast. Join me for a bi-weekly discussion on topics most relevant to women's health today. We are your source for medically accurate, real-world advice and all things related to your health and well-being as a woman. From menses to menopause, we've got you covered. I'm your host, Dr. Dana Smith, a fully practicing, board-certified OBGYN physician with close to 20 years experience. I am also the founder of the website that is 100% dedicated to women's health, myobmd.org. At myobmd.org, we write on all aspects related to women's health. Listen to our podcast, visit our website, subscribe to our newsletter, and follow us on Facebook and Instagram, myobmd.org. So, welcome to another episode of Straight Talk with My OBMD. I'm your host, Dr. Dana Smith, and I'm so excited to have with us today Dr. Kerry Anthony, who is your Menopause MD. And just so we have the background, I met Dr. Kerry Anthony through LinkedIn. Dr. Kerry Anthony, like myself, we're both board-certified OBGYN physicians, and we just have a passion for taking care of patients. And Dr. Anthony's passion have allowed her or driven her to the aspect of menopause and doing a deep dive into menopause, all of the myths, all the facts. We're going to hear them from Dr. Anthony. So Dr. Anthony, without further ado, I'm going to allow you, if you could, to introduce yourself to the listener and let us know how we can find you, including your social media handle, please.
Okay, awesome. Thanks for having me, Dr. Smith. So I am Dr. Kerry Anthony, a board-certified OBGYN, and my passion is in women's sexual health and that midlife transition, which includes perimenopause and menopause. And I founded Your Menopause MD, which is a telehealth company where I provide perimenopausal and menopausal consults to women in over 16 states. And my social media handle is also Your Menopause MD. So you can find me on Facebook, Instagram, TikTok, and YouTube at Your Menopause MD. And I provide educational videos on social media, kind of walking you through the myths, as well as helping you to advocate for your own journey, for your own health during this time. And really my passion in women's health has been there since I was in training. However, it was my own experience kind of going into perimenopause that really boosted the fire and led me to found my own company. I didn't recognize as a board certified OBGYN that symptoms that I was experiencing that weren't typical perimenopausal symptoms were indeed my entry into perimenopause. And I recognized that if I couldn't see this as a GYN who was already board certified in my own self, that many patients may not know that that's what they were experiencing. And when they go to see a physician, if that physician isn't trained in menopause specifically, they may miss it as well. So that allowed me to go and get additional training specifically in the menopause and perimenopausal transition so that I can offer that care to all of you.
And just so everybody knows, so we're both OBGYN physicians, and we both take care of women, can perform hysterectomies, deliver babies, and so forth. But Dr. Anthony took that extra step to go and did a deep dive into menopause.
Yes.
So her knowledge of the menopausal state is going to be more substantial than, for instance, a physician that has not done that. And so I was really excited to just have you on. And I'm so, it's interesting to hear you say you missed your own symptoms of menopause. Tell us a little bit about that.
Yeah, so really at about 48, I started having, it was really more emotional type symptoms. So I had a hysterectomy, and we're going to talk about how a hysterectomy can kind of play into not really recognizing where you are, because really not having a uterus then stops you from having periods. And one of the most common signs as we enter perimenopause is that we start to have changes in our menstrual cycle. So having a hysterectomy, I wasn't going to experience those changes in the menstrual cycle, but I also wasn't having hot flashes
Mm-hmm.
And I maybe had night sweats that started late in my late 30s. So that was something I had already been dealing with and really
Mm-hmm.
didn't think twice about it because it didn't change. But it was becoming more emotional, which I am not an outwardly emotional person. And I recognized that something was a little bit different.
Mm-hmm.
And my colleague, my old partner, I was seeing her for, she's an OBGYN. I was seeing her for something totally not related to any of those symptoms.
Mm-hmm.
And she just kind of looked at me and she said, I think you're perimenopausal. And I
Mm-hmm.
said, no, I'm not having any symptoms. I'm fine. Like everything's fine. And she's like, nope, I've never ever seen you like this. Like you are, this is not normal. You're not, nor this is not, no, this is perimenopause and you need to start hormone therapy. And I thought, no, I don't need to start hormone therapy. But she said, okay, just give it a try. Let's just try it and see
Mm-hmm.
if that kind of changes things. And it did. And it was really kind of that transition where I recognized everyone is not going to have a cookie cutter type symptom, right?
Mm-hmm.
And so for someone who's not usually emotional, just that part, of course, then everything else followed. Then the hot, then the hot flashes followed,
Came
and the
later.
night sweats got worse. And so, but this was just my entry, but she recognized it, and I didn't.
Mm-hmm.
And so that really led me. It was really after that that I started going to the menopausal conferences and then decided I wanted to become a menopause certified provider
Mm-hmm.
because I remembered me in private practice who
Mm-hmm.
may have seen a patient like me who said, oh, you're just fine. Like, this is just a
Mm-hmm.
little transition that you're going through. You'll
Mm-hmm.
be fine. We just need some stress management.
Mm-hmm.
And I recognized that that was not doing the best for patients.
And it's so
Yeah.
interesting, we learn a lot in our training, right? Because our training is at least 12 years and
Yes.
we learn so much, but we continue to learn as physician. And that is one of the beauty of our profession is that we just
Yes.
stop learning and we ask forgiveness for the patients who we learn something new
Yes.
saw a month, 6 months ago, and we're like, oh, I maybe could have handled that differently,
Absolutely.
because you now know more. But we are human and we are evolving.
Yes.
Tell us, for the patients now who may be experiencing who is not sure. So
Yep.
how do they define menopause? How do they know if they're menopausal or
Or perimenopause.
perimenopausal?
Yes. So in order to really talk about perimenopause, we first have to define what menopause is. And so menopause is defined as 12 months with no menstrual period.
Mm-hmm.
And that's going to be difficult. As I mentioned for myself, I had had a hysterectomy, so I couldn't use that time frame. I couldn't use the change in menstrual cycles or the lack of menstrual cycles. And the average age in the United States for menopause is about 51 and a half years old, but it can range anywhere from 40 to 56 or 57. And I've rarely had one patient that I can remember in the course of my career who was 58 before she had gone 12 months without a period, which is
Of
kind of
course.
miserable. But that's the average age. It's difficult to know if you've had a hysterectomy. It's also difficult if you're using hormonal birth control,
Mhm.
like a progesterone IUD or birth control pills, patch, or even a ring, because you may not have regular cycles. So it's a little bit more difficult. And in that instance, we would use more of the symptoms.
Mhm.
So menopause, 12 months with no period. Perimenopause is really defined as the time around or really before we
Mhm.
go into menopause. So
Mhm.
perimenopausal symptoms can start, if menopause can start as early as 40, perimenopausal symptoms can usually start very late 30s, early 40s, but they can last for 2 to 10 years.
Mm.
And
Time.
I know, the major symptom. Now, some patients have no symptoms, and they wake up one day, they've gone 12 months with no period, and they're like,
Mhm.
"Oh, I'm here. I've arrived." You know,
Lucky.
scot-free, never had any symptoms, but most of us, unfortunately, will have symptoms.
Mhm.
In perimenopause, the most common first symptom is some type of change in our menstrual cycles.
Mhm.
So that can be skipping periods,
Mhm.
having longer periods, so bleeding for more days or bleeding for less days,
Mhm.
bleeding heavier or bleeding lighter.
Mhm.
Now, we aren't all textbook patients and we're not made out of cookie cutters. So while that's the most common symptom, Some patients don't have a change in periods, or remember, those who are doing hormonal birth control or who've had a hysterectomy may not be able to use that bleeding as their first indicator. So we
Mhm.
look for other symptoms. The most common that we all talk about are hot flashes and night sweats.
Mhm.
But there also may be mood changes. There may be difficulty with concentration, or we call it brain fog, where you walk
Mhm.
into a room and you don't remember why you came in there, or you
Mhm.
can't remember where you put your keys or your phone.
Mhm.
You can also experience other atypical symptoms like joint pain or feeling a racing heart rate, feeling skin changes, decreased libido, or vaginal dryness.
Mhm.
And so there's so many symptoms that we kind of attribute to perimenopause that you might not have all of them, you just may have one.
Mhm.
And it really is looking at what your age is, what the cycles look like if you're still having them, and what symptoms you're having when we make that determination.
Mhm. Mhm. And now, one of the things I know you did not mention is the lab tests. And I know
Hmm.
a lot of patients, when I was in private practice, a lot of patients would come in and request blood work to see if they're in menopause. And, we had to go through that whole counseling of why that wasn't a good idea.
Yeah,
But go ahead and tell us, to the listener, what are your thoughts on using lab blood
yeah,
work for
yeah.
evaluation of menopause?
Well, I think it's important to know kind of what's going on behind the scenes. So I
Mhm.
talked about symptoms, but why are we having those symptoms? So
Mhm.
the symptoms that we're having in the perimenopausal time frame are due to fluctuating hormone levels. So estrogen and progesterone are the two main hormones that the ovaries produce.
Mhm.
And when we enter the perimenopausal transition, those levels are fluctuating almost like a roller coaster ride.
Mhm.
In our normal reproductive years, estrogen and progesterone throughout our cycle will slowly rise throughout the month. So it takes about 14 days to get that peak of
Mhm.
estrogen. And if we don't have a pregnancy that month, then those levels will fall. And then the lining of our uterus will shed, which is a period. And so over the course of 28 days, we have a very slow rise, a peak, and then a fall of those hormone levels, estrogen and progesterone. But in perimenopause, imagine a roller coaster where one day there's a normal level of estrogen and progesterone. The very next day, the estrogen is higher than it's ever been in the entire life cycle. And maybe 12 to 24 hours after that, it's undetectable. So it's
Mhm.
almost like you're having that cycle within 3 days versus in a 28-day
Mhm.
period. And it's that fluctuation of estrogen levels going from very high, which estrogen, some of us consider it maybe more of a happy hormone because when the estrogen levels are at their normal, we usually are feeling normal. But when we go from a high level, higher than ever, to a almost undetectable level, we're going
Mhm.
to feel changes in our mood. It's almost like a crash
Right.
of a roller coaster. We're going down and we're going to hit the ground and feel those symptoms more severely. And
Mhm.
because of that, it's difficult when we check your levels of estrogen and progesterone
Mhm.
because, as I mentioned, every other day the level may be normal. So, what
Mhm.
happens is I may see a patient for a perimenopausal consult who comes to me because she's already had lab work done. And it is probably at least 2 or 3 times a week when I see a patient who says, I had my lab work done and the doctor told me it's normal. They told
Mhm.
me I'm normal because my estrogen and progesterone levels were normal, but something is wrong with me. And so that's why we really try to avoid testing the estrogen and progesterone levels because they could be normal. Now, they could be high
Mhm.
or they could be low,
Mhm.
but that does not give us a full picture and it doesn't allow us. And most commonly, the levels are normal. And so patients are told there's nothing wrong because your levels are normal.
Which
Now,
is.
there are some labs that we might want to test, and usually I will recommend these.
Mhm.
So, when we're having perimenopausal symptoms, there are other disorders that can kind of mimic those same symptoms. For example, a thyroid disorder, either hypo or hyperactive thyroid. So an overactive or an underactive thyroid
Mhm.
can mimic some of the symptoms. Patients can have irregular periods with a thyroid disorder. They can feel palpitations or they can feel their heart racing. They may have temperature sensitivities where they're extremely hot or having hot flashes or even night sweats. And so we can do thyroid testing, which is just a simple lab draw, and
Hmm.
that will allow us to rule out a thyroid disorder as a cause for these symptoms. We also would usually want to just check a complete blood count where we check the white blood count and the hemoglobin, our red cell count, to make sure that we don't have an issue there that could also cause hot flashes or night sweats. So we want to rule out the things that mimic menopausal or perimenopausal type symptoms, but checking our specific estrogen and progesterone levels don't
Hmm.
really give us a clear picture of where we are in the perimenopausal transition.
Absolutely. And that's so important because one of the things we want to do, a patient may come to us and say, I'm convinced I have this diagnosis, whatever that diagnosis is. And you may or may not be right. But our job as the physicians who are caring for you is to make sure whatever diagnosis you have is an accurate diagnosis. And
Correct.
so we have to make sure that, hey, it sounds like this, but we have to make sure it's not something else, because then you're going to be treated and be subjected to medication and treatment, which does have side effects and
Yes.
isn't helping you because you don't have the correct diagnosis. So it's just so important to make sure when you see your physician and you go through this process, we just are patient, go through the process, and it's extremely important to make sure you have an accurate diagnosis before you start treating, because you start
Yes.
treating not knowing what you have, and it just confuses the whole picture
Yes.
and
Yes.
delays the true diagnosis even
Yeah.
further. So thank you for taking that time, letting us know why it's so important to see your physician, see a physician who is familiar with menopause,
Yeah.
and the menopausal symptoms, and someone who can really accurate provide you with an accurate diagnosis of
Diagnosis.
what you're going through.
Mm-hmm.
Now that
Mm-hmm.
you have had a diagnosis,
Yeah.
and now, okay, now the patient's saying, okay, what now?
Yeah.
So many people have an opinion. 20 years ago, hormone was just like the rave, right? Everybody wanted the hormones, and now
Mm-hmm.
nobody wants hormones. It's like,
Yes.
you know,
Yes.
and we do recognize hormone as being the gold standard, but go ahead, tell us a little bit more about what is your approach to the treatment
Yeah.
of
Yeah.
menopause?
So again, as you said, Dr. Smith, hormones are the gold standard for treating. And we talked about the fact that, and we really actually didn't hit on what's happening with those hormones once we're menopausal. So we talked about perimenopause. It's a roller coaster ride. But
Mm-hmm.
once we're menopausal, the ovaries, the factory is closed. So we're not making estrogen and progesterone anymore. So
Mm-hmm.
once we've gone those 12 months without a period, that's when we're no longer producing those two hormones. And so that's really why we consider hormone therapy the gold standard. And when we're perimenopausal, we actually have a couple of different options to treat it.
Mm-hmm.
It depends on whether or not we still need to prevent a pregnancy. So it's important to understand that in perimenopause, there still is a risk for pregnancy. So even though these hormones are taking you on a roller coaster ride,
Mm-hmm.
and the ovaries are deciding that they're trying to stop working, every now and then they will produce an egg to be fertilized.
Mm-hmm.
And so during perimenopause, I've seen it. I've had patients, oh, I'm 49 and I think I'm menopausal. And then suddenly here's a positive pregnancy test.
Mm-hmm.
So in that perimenopausal transition, we have to determine, do we still need to prevent a pregnancy? And
Mm-hmm.
if we do, many doctors will start a hormonal type of birth control. So either an IUD that goes inside the uterus that has progesterone, or a birth control pill, the patch, the ring, so that you're getting, with everything except the IUD, you're getting a little bit of estrogen and
Mm-hmm.
you're also helping to prevent an unintended pregnancy. Now, the estrogen in a birth control pill or the patch or the ring is a little bit different than the estrogen we use for hormone therapy. So that estrogen is designed to tell your brain that we don't need to ovulate anymore. So it
Mm-hmm.
really shuts down all those signals that we get
Mm-hmm.
to reproduce, which then can result in more of a decreased libido, possibly more vaginal dryness. And so when we talk about treatment, we really have to talk about what symptoms the perimenopausal patient is having.
Mm-hmm.
So if you come in and you say, I'm having hot flashes and night sweats, but you're also having a decreased libido, then a birth control pill may not be the best option because we may suppress that libido even more. So this is the key when we talk about menopausal training. So Dr. Smith, you and I, when we were in medical school, and when we were in residency, we didn't really get a focus on how to treat perimenopause. It was just once a patient has gone 12 months without a period, you can offer hormone therapy. And that was it. There was never a focus on, and what do you do for those women who might spend 2 to 10 years having symptoms that may need treatment?
Mm-hmm.
And so now we know after 30 years of research that we can offer hormone therapy even to the perimenopausal patient, as long as we know that they're not at risk for an unintended pregnancy. And so that's the same type of hormone that we would use for a menopausal patient. And so that's estrogen and progesterone.
Mm-hmm.
And this is the gold standard because it is an estrogen instability and then a deficiency that is causing the symptoms.
Mm-hmm.
So it's that lack of estrogen that causes those mood changes, that causes the hot flashes, that causes the night sweats. So if we can give estrogen back, then that will help treat the symptoms.
Mm-hmm.
Progesterone is also necessary, however, if we still have a uterus in place. Because if we give estrogen alone, estrogen is responsible for thickening the lining of the uterus. So when
Mm-hmm.
we're having our normal menstrual cycles before we ever hit perimenopause, it's the estrogen that thickens the lining of the uterus. So that estrogen that I mentioned that slowly rises throughout the cycle, it produces a thick lining for the uterus so that if we have a fertilized egg, it can implant into that environment. And so
Mm-hmm.
if we give estrogen without progesterone, progesterone comes in and it keeps the lining thin. So
Mm-hmm.
if we use estrogen in menopause for women who have a uterus, we also have to give them progesterone because progesterone will help to keep the lining thin. But for patients who've had a hysterectomy, estrogen only is the option because it is estrogen that helps to kind of really treat all of the symptoms.
Yeah, they don't have a uterus. You don't have a uterus
Exactly.
about.
Then you don't have to worry about aligning. And
Mhm.
so once we start estrogen therapy, which can be an oral tablet, although we prefer a transdermal method like a patch or a gel or a spray now because it has a lower risk for blood clot formation, which we can kind of talk about in a little bit more detail.
Mhm.
But we've got multiple options to treat with estrogen.
Mhm.
And then the progesterone we usually give as an oral tablet. So every now and then I have a patient come in and says, they're taking a progesterone lotion.
Mhm.
And there's really no evidence because we don't have studies to show that a progesterone lotion that you're rubbing into the skin actually helps to keep the lining of the uterus thin. And
Mhm.
so we rather try what we know works to keep the lining thin, and that's going to be an oral progesterone. And so we can try this in a perimenopausal patient as well as in menopause. And that is actually my preferred method of treatment for
Mhm.
perimenopausal patients as well, because it really helps to treat those symptoms better than a birth control pill.
Mhm.
But if we need the benefit of pregnancy prevention, we may have to do a birth control pill or some other method so that we don't have an unintended pregnancy.
Least for a while.
Yeah. Yeah,
At least for a while.
exactly. Exactly.
And I want to just point out one of the things that Dr. Anthony so eloquently stated in regards to the need for the progesterone therapy to prevent the thickening of the lining of the uterus. And what we are driving at is that thickening of the lining of the uterus, if that is left unchecked for
Yes.
months and months and even years, you can go on to develop endometrial cancer, type of uterine cancer.
Yes.
And so it is very, very important that we know that we are not harming the patient in the treatment that we're given. And so
Mhm.
that is why we have to also give a protective, a drug that protects against the formation,
Yeah.
against developing endometrial cancer. Because of course, then we would be harming, right? That's
Yeah.
not an appropriate trade-off for your symptoms. So again, if you have no uterus, right, you don't have to worry about that. Then you can go ahead and just take the straight estrogen. But if you have a uterus, you really want to speak with your doctor about how you're going to protect the lining of your uterus,
Mhm.
how you're going to prevent the form developing endometrial cancer.
Yeah.
Um, down the line. So that's part of that's why it's so important to be in the hands of someone that really knows what they're doing, because these are the things that we have to consider.
Yeah.
So that is part of the hormonal treatment
Yep.
for menopause, and it works really well, right? Most patients that are on hormones, they're like, "Oh, I feel great."
I love it. Yes. Well, and it does take, at least 2 to 3 months on a regimen to know how well it's going to work.
Hmm.
Most patients within 2 to 3 weeks will say, I'm starting to feel um, a relief of symptoms. And usually that first thing that we feel is relief from hot flashes and night sweats. And
Hmm.
then slowly over the course of those 2 months, we feel a change in mood and maybe even energy because we might be sleeping better.
Hmm.
One caveat, well, one benefit, I won't call it a caveat, but a benefit of the progesterone, while it is protecting the lining of the uterus, the type of progesterone that most of us use now also makes you sleepy. So we tell you to take it about an hour before bedtime. And if you're already having sleep issues not related to waking up with night sweats, progesterone comes in when we add it and it helps you fall asleep. So there's a benefit there in addition to just protecting the lining of the uterus.
Oh, awesome.
Yeah, yeah,
So, those are some of the approaches for hormonal treatment of menopause. Now, there are some women who do not like one hormone, and there's some women who are not appropriate candidates for hormone who
yeah,
should not be taking hormone, right? So, if you have
absolutely.
a breast cancer diagnosis or a history of breast cancer, um, or certain other conditions that are hormonal dependent, you do not want to be taking the estrogen and progesterone we've just described, but you still have symptoms and you still need to be treated. So,
Yeah.
Dr. Anthony, what is your approach to the patient that may not want
Hmm.
hormonal therapy or does not qualify for hormonal therapy, but is still having these menopausal
Yes.
symptoms?
Yes. So we really have to kind of look at what the symptoms are that we're treating.
Mhm.
And as you mentioned, patients who have had breast cancer, patients who've had a stroke or heart attack or a blood clot develop in their leg or lung, we call that a DVT or PE, or patients with significant liver disease, those patients would not be candidates to take hormone therapy with estrogen or with estrogen and progesterone. And so we really have to look at what symptoms they're having. There is a newer medicine on the market, and this one, I think they premiered commercials in last year's Super Bowl, and it's called Veoza,
Mhm.
and that's the brand name. And right now, there's only the brand name available, and it is specifically for hot flashes and night sweats. Now, the medicine has been on the market just almost at the 2 years now, and it has been a godsend for patients who are recovering or surviving breast cancer and patients who've had strokes and heart attacks. Because it's not non-hormonal, they are able to take this medicine. And the medicine is a tablet that you just take once a day, and it actually works in the brain, in
Mhm.
that temperature regulating center of the brain. And what patients have experienced with this medicine is within usually 2 to 3 weeks, a dramatic decrease in the frequency and the intensity of hot flashes and night sweats.
Mhm.
So, this is probably a first line treatment now for patients who aren't candidates for hormone therapy or who choose not to
Mhm.
take hormone therapy.
Exactly.
Now, it's a little bit difficult to get this one approved. So we have to fight a little bit with insurance, even though this was developed for those patients who weren't candidates for hormone therapy.
Mhm.
Sometimes we still have to try some off-label medicines, and we'll come to those in just a few minutes before we can get this one covered. But it's a once a day. There really aren't any unwanted side effects that patients experience with this. However, we do have to check liver labs.
Mhm.
So when this drug was being tested in clinical trials, they did see a slight elevation in some of the liver labs that we check for. And so
Mhm.
before starting this, we do have to evaluate that. It is a lab draw, and we
Mhm.
just do a baseline to make sure that liver function tests, those are the liver labs, look
Mhm.
normal. And
Mm-hmm.
then we repeat those labs once a month for the first 3 months while taking the medicine.
Mm-hmm.
After the first 3 months, we repeat it at 6 and 9 months. And after that, we can stop if we did not see an elevation. What happened in the clinical trials is we saw a slight elevation in patients taking the medicine during that 1 year time frame, and then we did not see any further elevation. So if we are able to make it to the 9 month mark and we don't see that dramatic change in those labs, then we can continue it
Mm-hmm.
afterwards and we don't have to check that level anymore. And
Mm-hmm.
so this really, to me, of course, it's it's first line for those who can't take
Sure.
hormone therapy. However, we still may have to try some other options before we can get that one approved. And
Mm-hmm.
so our other options, we've got a couple of different categories.
Mm-hmm.
So anti-anxiety and antidepressants are one category of medicine that we can try for hot flashes and night
Mm-hmm.
sweats, and
Mm-hmm.
also for sleep. And
Mm-hmm.
because they're anti-anxiety and antidepressants, also for mood. So
Mm-hmm.
that group of medicines does have one that's FDA approved, and that one is called Paxil. So that's an anti-anxiety antidepressant that's actually approved to treat menopausal symptoms. So in that category, we have the one that's FDA approved, but we have several others that we use off label. So
Mm-hmm.
we've got 5 or 6 different options just under that umbrella
Mm-hmm.
that we can use to treat the symptoms.
Mm-hmm.
Now, again, it's usually just to treat hot flashes and night sweats, but we get the benefit of usually seeing a stable mood and better sleep, which then helps with brain fog and helps with fatigue.
Mm-hmm. Mm-hmm.
Now, there's also another category. There's a nerve medicine that we use for nerve pain. It's called gabapentin.
Mm-hmm.
That one can also be used in menopause and perimenopause for
Mm-hmm.
hot flashes, night sweats during the daytime as well as at night, and also for sleep. So
Mm-hmm.
that is another option that is not an anti-anxiety antidepressant.
Mm-hmm.
Some of the concerns that we have when we talk about anti-anxiety and antidepressant medicines is that they too can decrease libido. And they also have a side effect of the possibility of weight gain.
Mm-hmm.
And so, again, we kind of talked about symptoms in the beginning. We didn't mention the weight gain, but that is probably one of the top 3 complaints that perimenopausal and menopausal women complain about. And so we have to be really careful if we choose an anti-anxiety antidepressant and really be very realistic when we start it, because there may be a side effect associated with weight gain as well as a decreased libido. So we
Mm-hmm.
have to weigh symptoms and how intense those symptoms are, and maybe choose a different category of medicine to treat outside of those anti-anxiety antidepressants that cause weight gain. And so there is one that we use that's not in that same umbrella of medicines, and it's Wellbutrin and so or bupropion. So that's an option that does not have the side effect of weight gain or decreased libido. So it's a great option.
Mm-hmm.
It sometimes can increase anxiety. So again, each of these non-hormonal options, we really kind of have to weigh what side effects do we get with it, and not everyone will experience side effects
Mm-hmm.
versus what benefit do we get with those.
Mm-hmm.
There's also a very old school blood pressure medicine that we can use called clonidine, specifically for hot flashes and night sweats.
Mm-hmm.
And there's also a medicine that we use for overactive bladder
Mm-hmm.
that can help with hot flashes and night sweats. That one comes with the side effect of dry mouth, but we've got multiple prescription options that we have clinical trials that have shown there is a benefit in alleviating symptoms.
Mm-hmm.
But I will just stress it's more hot flashes, night sweats, mood, and sleep.
Mm-hmm.
When patients take hormone therapy with estrogen, the reason that they continue the medicine is for the beneficial side effects. So while it's only FDA approved to treat hot flashes and night sweats and to decrease our risk for osteoporosis, the
Mm-hmm.
patients who take hormone therapy come back and they say, these are the things that it helped treat, even though this is not why it's labeled. This is
Mm-hmm.
not why we prescribe it. It helps with brain fog. Patients come back after 3 months and say, I can concentrate now. I
Mm-hmm.
remember where I put my keys. I remember why I walked into the room.
Mm-hmm.
My joint pain has improved. I don't feel like I'm creaking when I get out of bed in the morning.
Mm-hmm.
They feel like sleep is better, so there's more energy, so they complain of less fatigue. And
Mhm.
even those who complain that they kind of feel like their hearts are racing, a lot of times that will also go away. Sometimes we will still need a cardiac workup to make sure there's not a heart issue. But
Mhm.
most of the time when I see patients, they've already seen a cardiologist because their doctor has sent them to so many different specialists because
Mhm.
of all the different symptoms that they have, that we already know that the heart is clear. But these are all those beneficial side effects. That is why patients say, yes, it helped my hot flashes and night sweats, but I feel normal again. And so
Mhm.
we don't get those same benefits with the non-hormonal therapies.
Mhm.
Yeah.
Mhm. So the non-hormonal therapies are really great options.
Yes.
You have to speak with your physician because the choice of the non-hormonal therapy will really depend on what your vulnerabilities are. You mentioned the value of using the non-hormonal therapy for the treatment of menopause. The patient has to really speak with her doctor. They have to have a discussion regarding what her medical vulnerabilities are. If her concern is anxiety, then that may steer them in one direction. If her concern
Yes.
is weight gain, then that may steer them in another direction. So you are selecting because for this group, the non-hormonal therapy, you do have more options available to you, but that also has different side effects that you may or may not experience. So
Yes.
you just want to really speak with your doctor so you can have the medicine that is most suitable for your condition, for
Exactly.
you and what your concerns are. So that's wonderful. And I just want to take a pause and recap. We're talking to Dr. Carrie Anthony. Dr. Carrie Anthony is your menopause MD. She is a board certified OBGYN physician, just like myself. However, she has taken the time to dive deeper into menopause. And so she has a deeper understanding of menopause. And so I was really so excited when she agreed to speak with me on the Straight Talk with My OBMD podcast. And so far we have covered what menopause is, what perimenopause is, how to know when you are in it, how do you diagnose it, and the treatment options, including hormonal and non-hormonal treatment, because not everybody necessarily wants hormone and not everyone should necessarily be on hormone, depending
Totally.
on your medical history. So, Dr. Anthony, is there anything you wanted to add? I want to talk about some of the herbal or natural supplements for treatment, but is there anything you wanted to add before we moved on to the how other ways that patients can handle their menopausal symptoms?
No, I mean, I think you really covered it. It really is a customized treatment plan that you have to be able to sit down and have that conversation with your physician. And, if your physician isn't comfortable treating, then, seek a menopause provider. So someone who has done the extra step of training to treat menopause and perimenopause. As we mentioned a few times now, it's just not part of the standard medical school curriculum or that of, residency once we're out and actually seeing patients in that second step of training that happens after medical school. And so it really takes just a little additional studying in order to really be able to offer all the options and treatments. Yep.
Okay. All right. And then for the patient who wants to self-medicate, self-treat, maybe they have diagnosed themselves as menopausal, or they may have been diagnosed by a physician and they say, I don't want to deal with any of that stuff. I don't want to
Mhm.
deal with prescription drugs at all, no
Yeah.
hormones, no prescription drugs. What are some of the things that they can do without a medically supervised treatment that can help with their symptoms?
And so I would say first, look at lifestyle changes before we even
Hmm.
get into the herbal. There definitely are some herbal products that we're going to talk about, but just these are things we can do even before we have that first visit. So avoiding the hot triggers, wearing cool clothes or moisture wicking clothes. Having a fan, that's how it starts. I've got my fan right here blowing on me, and I don't go anywhere really without some type of portable fan. But using meditation or breathing techniques when a hot flash starts, There's
Mhm.
lots of, there's some YouTube videos on square pace breathing. There's also some yoga poses that you can try to really kind of reset yourself in that mind frame when you feel a hot flash coming on. And also, a cooling pad on the mattress. So that is something, when I mentioned my symptoms and how
Mhm.
I really kind of missed the onset of perimenopause for myself. I mentioned that I also had started having night sweats in my 30s. And what
Mhm.
we invested in first was an industrial ceiling fan for the bathroom that would blow in the room. We also then added, because that didn't work to help my night sweats, we added
Mhm.
a individual air conditioning unit that blew from the bathroom into the bedroom. And then eventually, because that did not work, we got a pad that goes on the bed to keep the bed cool. So there's a few different products like this. So there's the bed jet, the chili pad, the Uller system. So there's a few different things that you can buy to either put that's a pad that goes on your bed, or a fan that kind of goes under the sheet that blows cool air throughout the night. And so using
Mhm.
that, I stopped having night sweats. So of course, in my mind, I use it every
Mhm.
night. It's routine. So I wasn't
Mhm.
thinking about that when I started having other symptoms. Was like, oh yeah, well, you already started having night sweats years ago. So this could be perimenopause. So these are
Mhm.
just some of the things that changes we can make at home or when we're out and about to really help decrease the discomfort that's happening in the transition. But there
Mhm.
are also herbal supplements, and probably the tried and true, the oldest one is black cohosh. And while our societies don't really have literature, so we don't have the clinical studies and clinical trials that we do for prescription medications when we talk about herbal supplements. These are supplements, so they don't undergo an FDA approval process. So we don't have studies really to back them up. And so some studies you may read show that maybe it's just a placebo effect that people say these medicines help with hot flashes. But what we have to look at is what we see clinically. Have I had patients who've tried some of these herbal supplements who say, yes, this has helped me? And that's yes, that's a yes. So
Mhm.
black cohosh is probably one of the most common that's been around for years, and it really expanded in use in perimenopausal and menopausal patients when the Women's Health Initiative study came out in the early 2000s and people stopped taking hormone therapy. This was probably one of the first herbal supplements that they used, or even patients who just always were natural. They knew that once they started having symptoms, black cohosh was going to be the herbal supplement that they were going to try. And so I definitely have had patients who've tried that and feel that it helps with hot flashes and night sweats. Evening primrose oil
Mhm.
is another herbal supplement. We use that more commonly in patients who are complaining of breast tenderness. But what I have seen in
Mhm.
clinical practice is some patients take that before bedtime and feel that it helps with night sweats and helps them to sleep. Now,
I'm sorry, you we lost you a little bit. You said the evening primrose oil
yes.
helps with sleep.
Yes, and so I have some patients who use that right before bedtime and
Mhm.
feel that it helps with sleep and night sweats.
Oh, okay.
And then there's newer herbal supplements that we've seen probably in the last 3 to 5 years. And so one of those, of course, is ashwagandha.
Mhm.
So ashwagandha really hasn't been shown to help with hot flashes or night sweats. However, what I've seen in patients is that they feel that it helps with anxiety type symptoms. So it helps give them a sense of calm and peace, which
Mhm.
helps with sleep.
Mhm.
Now, on the flip side of that, I have had patients complain that they feel like ashwagandha has made their heart race. So, with
Mhm.
that supplement, what I would recommend is taking it in the daytime first, just to see, like when you're not going to be at work. So, if you're off on weekends, maybe taking it on a
Mhm.
weekend, just to see, will it help make you sleepy, or do you feel like it helps give you more energy to decide which way you might want to take that one?
Mhm.
And then there's also maca root powder. Not the
Mhm.
same as matcha green tea, but maca, MACA
Mhm.
powder. I've had patients try that herbal supplement, also helping with sleep, but
Mhm.
also helping with libido. So if you look that one up, There's even one in one of the natural grocery stores, and it's labeled for men's sexual health. And it's just little
Mm,
capsules with that powder inside, but you can also buy it as a loose powder to add in smoothies. While I've
mm,
had very few patients try it, there is one patient that I have had report back to me who feels that as though this one helped with libido. Now, Dr. Smith, what I would say is if we want to try an herbal supplement, I would recommend trying only one of these at a time and giving it at
mhm,
least 2 to 3 weeks of use to really know how well it will or will not work for you.
mhm,
I also recommend buying that yourself from your local grocery store or pharmacy or your whole food type market or Sprouts or
mhm,
natural type of grocery store versus going online and buying a menopause labeled supplement,
mhm,
because usually these are the same ingredients, but those supplements will cost maybe $99 to $100 a month versus you getting it from a local pharmacy where it may be $9 a bottle or $19 a bottle. And
mhm,
so whenever I see those supplements, I just, take a screenshot and blow up the ingredient list if they don't already have it on there to look at the ingredients. And if it's ashwagandha, well, I can get ashwagandha at my local pharmacy. I don't have to buy this or subscribe to a monthly delivery service to get a
mhm,
menopausal vitamin. So this is
mhm.
kind of what I would recommend if we wanted to try the herbal supplement route, that we do it ourselves and just kind of get those ingredients on our own.
Gotcha, gotcha. And then also the good thing about getting on your own too is that you know that you're getting a pure substance as opposed to mix something
Exactly.
that's with other things. So it may say, on the label, hey, it has ashwagandha, but when you actually look on the ingredients, that's maybe the second to last ingredient. It has very little of
Yes.
it. And then now you're going to say, well, I tried the ashwagandha, it didn't work. Well, you didn't
Yeah.
really because
Yeah.
it was just so little of that substance in whatever you were taking. So
Exactly.
it's always helpful to get the pure ingredient because then one, you can know if it actually helps you, and also if you do happen to have some
Hmm.
wanted side effect from it, you'll find that out also, and you'll know,
Exactly.
well, this causes this, as opposed to, I don't
Exactly.
know, it has 10 different ingredients. So
Exactly.
that's always super helpful. Now, there's so many presence on social media and other media that states, that everything you experience is menopause. And we want to make sure that, again, we talked about the importance of making sure you're appropriately diagnosed. So I wanted to just spend a little bit of time just talking about, hey, what are some of those symptoms that you may think, hey, this may be more than menopause, that, are you taking the hormones but still crying and feeling
Yes.
not in the energy or the desire to take part in your every routine activities? When should we get alerted that, hey, this is really more than menopause and this may be something else?
Exactly. And I think this, Dr. Smith, is where we talk about continuing to follow up with your physician. So, for most of us who do specifically menopausal and perimenopausal care, once we start therapy, we are following up. If we're starting new treatment, we usually are following up at that 3 to 4 month mark because it takes about 2 to 3 months to really know how well the medication is working for you. And there are patients who are going to be diagnosed with anxiety disorder or depression during this time frame who may need an anti-anxiety or an antidepressant medication. And so what we really want to look at is if your symptoms are better. So let's say you came in with hot flashes and night sweats and just a little bit of tearfulness or feeling a little bit of anger, and you start your hormone therapy and it's working well for you at that 3 month mark, and all symptoms have improved. Then we know that this is probably going to be the best therapy for you. If you're having difficulty getting out of bed, you're crying most days, you're not enjoying any of the activities that you were used to, you're starting to lose weight because you don't have an appetite anymore. That is going to give us a picture more of a depression disorder versus menopause. And so that's when we really want to have that follow up with the physician and say, my hot flashes went away when we started this therapy, whether it was hormone therapy or a different type of therapy, but I'm still having difficulty enjoying the things that I used to enjoy. I can't get out of bed. Those are going to be the signs that this may be more of a depression type of scenario. And we may really need to focus on starting an antidepressant or starting therapy with a certified counselor or with a psychologist or with a psychiatrist. And so we sometimes will diagnose a mental health disorder in this time frame, and maybe there could have already been an underlying issue, but because we were peak of our career and we were raising kids, we were so focused on everything else that maybe we overcompensated and we didn't realize it was there. Other issues, I'll just, joint pain. So a lot of patients who are menopausal complain of joint pain, and there is a whole syndrome, this musculoskeletal syndrome of menopause, which has now been defined, and there's papers really to support it. But if we're having multiple joint pains and we're not seeing any improvement when we start therapy, there are other disease processes that are there. There's some inflammatory diseases, there's arthritis. So there still may need to be a workup for some of the other symptoms as we're labeling it all under a perimenopausal or menopausal umbrella. Yeah.
Absolutely. Absolutely. Thank you so much for articulating that and for saying that, because that's one of the things that truly does frustrate me is when, everything as women, right? We're familiar with, we treat patients, we get calls from the ER physicians. I have as women, patients tend to focus on their pelvis, right?
Yes.
Like is related to, oh, this patient excruciating pain and she has a 3 centimeter ovarian cyst, and we're like, okay, and like
Yes.
that's
Yes.
not the cause of her pain. That
No.
so it's so we're so conscientious of the fact that so many a lot is for women, a lot is our medical when people are view our medical lens through our pelvis. And
Correct.
so our reproductive system becomes front and center when we have any complaint, right? There's a lot of people first focus on our reproductive system before they go on to other things. And we just want to make sure that even at this stage of life, when our reproductive system may not be as active, that we are making sure that patients are diagnosed correctly. Because if you do have an untreated anxiety disorder, untreated depression, or even arthritic condition that can seriously impact the quality of your life, you
Yes.
want to make sure that you are spending your money, your time on a treatment that will help you and is the appropriate treatment for you. So again, we just really want to stress the importance of having the accurate diagnosis. And so it's
Yes.
important to see your physician. Dr. Anthony, hats off to you. Thank you so much for being a guest on Straight Talk with my OBMD. And if you could just tell us again about your social media handle and your website.
Yes, so my website is www.yourmenopausemd.com, and my social media handles across Facebook, Instagram, TikTok, and YouTube, where I've got a few more educational videos, is also Your Menopause MD. So I'm at Your Menopause MD on all the social media platforms, and like I said, I offer educational videos. Sometimes we talk about the funny things that just are driving us crazy during this time frame, and I just welcome you to join me there.
All right. Well, we are so excited. And of course, we'll also link Dr. Anthony's information on our social media at myobmd and myobmd.org. And we're so grateful to you, and we are thankful for you to guest on the Straight Talk with My OBMD podcast.
Thank you for having me.
Thank you for listening to another episode of Straight Talk with My OBMD podcast. To learn more about this topic, visit our website at myobmd.org. Subscribe to our newsletter, follow us on Facebook and Instagram. I can't wait to spend more time with you on our next episode of Straight Talk with My OBMD.